My name is Richard Isaacson. I work at the University of Miami Miller School of Medicine, and I work in the Department of Neurology. Sure. So at the International Congress on Alzheimer's Disease this year, they summarized findings of 3 groups of physicians, physician scientists who specialize in Alzheimer's. And what they did is they're trying to advance the diagnosis of Alzheimer's disease to the next generation. And currently we've used the same diagnostic criteria for the last 20, 25 years. And now what we're going to try to do is not only use a clinical diagnostic criteria, meaning a progressive history of short-term memory decline, which is the characteristic findings in Alzheimer's. We're now going to use a variety of other biomarkers or surrogate markers. These surrogate markers are in the lines of 4 different categories. One is cerebral spinal fluid or spinal fluid CSF markers in terms of A-beta 42, one of the pathologic proteins in Alzheimer's, as well as hyperphosphorylated tau and also tau. You can look at the levels of these, and depending on the levels, you can determine what the likelihood of Alzheimer's pathology is in the brain. The other marker would be in the brain, and that's doing imaging scans. One type of imaging scan is using a PET scan or a positron emission tomography. You can now use a labeling agent, something called, for example, Pittsburgh compound B, which actually binds to the amyloid in the cells. And you can actually see the amount of amyloid deposition, the pathologic protein in Alzheimer's, that's in the brain. You could also do another PET scan, which just looks at the activity in the brain and how much glucose is uptaken. And if the amount of glucose is low in the frontal, parietal, and temporal lobes, for example, that would be more consistent with Alzheimer's. You can also do a regular brain MRI, and that's the convention that I use mostly, and that's looking at basically structures in the brain responsible for memory. For example, the hippocampus, and if you have hippocampal atrophy or entorhinal cortex atrophy, you can see this on a regular plain MRI of the brain, that will now be an additional marker for the diagnosis of Alzheimer's in combination with the clinical history. The 4th category is genetic testing, and the genetic testing that was commented on at the Alzheimer's meeting was more of the early onset genes. For example, presenilin 1, presenilin 2, and amyloid precursor protein. Right. Actually, this is really from multiple studies over many, many years. There's a variety of studies both in the United States, Europe, and all over the world looking at all of these various biomarkers. There's also a variety of research trials, published and unpublished, and this consensus was based on not only scientific evidence, but also expert opinion. So there's really not one main cohesive trial that was done, but it was actually a variety of scientific studies and also expert opinion. Yeah, I don't think we're there yet. I think we've made a lot of progress in terms of diagnosis of Alzheimer's and using these type of surrogate markers. But in terms of one specific of these 4 things, I don't think we're really there. In terms of the genetic testing, there are a specific subset of genetic abnormalities for early onset Alzheimer's. This is quite different from the routine. 95% of Alzheimer's disease is not these 3 markers: amyloid precursor protein gene mutation, presenilin 1, presenilin 2. So in the very small minority of Alzheimer's disease, in this 5%, I would say, or less, the genetic typing is truly probably the best of all of these surrogate markers if I had to choose just one. This specific study is just another one specific study that these experts used in order to come to these consensus expert recommendations. So in this one specific study, this was a very nice long study that looked at patients over time and did they develop Alzheimer's. A lot of studies try to correlate initially, does someone have Alzheimer's disease, do the test, and then look at the brain later. In this case, they followed patients over several years. So this is just another study that gives credence. The reason why that got so much evidence and so much publicity in the press, for example, was because in using the combination of a signature of 3 biomarkers, instead of just using one biomarker like an MRI or a PET scan or one protein in the spinal fluid, it looked at a signature of a combination of A-beta 42 levels, hyperphosphorylated tau, and tau levels in the cerebral spinal fluid. And if a patient had the signature of these 3 in the correct proportions, then those patients, it was highly, highly predictive of conversion to Alzheimer's disease. At this point, I don't think that these criteria, these research studies in my own specific clinical practice is going to have a profound impact on the way I treat or I suggest different avenues for preventing or possibly delaying or attenuating the progression of Alzheimer's. In my opinion, every single person is essentially at risk for Alzheimer's disease. Whether you're 85 years or older and you have a 45 to 50% chance of having Alzheimer's, or you're 71 and over and have a 1 in 7 chance of having dementia of all types, every single person out there has a significant risk for Alzheimer's. So that's why I advocate for a very comprehensive preventative scheme that, while is not proven, in general, living a good, healthy lifestyle and taking advantage of regular primary care visits as well as a variety of other interventions that are safe, I think every patient out there, whether you're concerned or not concerned about Alzheimer's, needs to start making the right decisions, and the earlier the better. So currently we make a diagnosis of Alzheimer's based on a progressive clinical history, and then using some of these new supportive biomarkers, we can confirm that diagnosis before we actually have a sample of tissue in the brain. In general, once these pathologic proteins are deposited in the brain, the amyloid is there, it's clumped together, the tau is there, it may be too late. That may be already past the most opportune window to intervene. So what we need to do, and where the science is going, is before the clinical onset of symptoms and before the deposition of these amyloid plaques in the brain that we see on a pathologic slide after death, what we need to do is figure out what types of diagnostic tests can we do 10, 20, or even 30 years before the diagnosis is routinely made. Because if we can say this person has a very high likelihood of developing Alzheimer's, we can be even more aggressive with preventative techniques. The one downfall today in 2010 is we don't have the best evidence for prevention in a variety of areas, but I think we're making significant progress. So I do not advocate for genetic testing, for biomarker testing, for any of this testing right now. I don't think we have enough evidence in 2010 to warrant widespread testing. I think some of the issues you brought up are extremely valid. I think one of the most important issues is, what is the level of anxiety and depression, and what can happen when someone finds out that they're at risk for developing Alzheimer's in 10, 20, or 30 years, what that does to them not only psychologically but physically and otherwise. So, for example, there was a recent study done in the journal of, published in the Journal of Neurology that looked at this, and that study over a 1-year time period said that there was a very slight increase in anxiety, for example, but at 1 year there was no additional depression and there was no additional other psychological problems based on finding out if you are at a genetic risk for Alzheimer's. The problem is this was only one study, and this doesn't tell you how someone's psychologically going to handle the news 5, 10, 15, 20 years later, especially if you're young when you get the information. The other aspect is will people say, oh, I'm going to get Alzheimer's disease, that's it, I'm through, I have to, my life is over, and I mean, it's tricky. I don't think enough research has been done, and I would not advocate at this time for widespread use of these studies.